right. I'm going to just warn everyone that I have a lot of information to present in 8 minutes, and I have a tendency to speak what's been described as distractingly fast. So I'm going to try to be as clear as possible, but just kind of buckle up. Okay, so thank you so much for the opportunity to speak today. I'm going to be speaking about intra-individual cognitive variability in a young preclinical cohort. So the take-home message for today's talk is that differences based on subject characteristics need to be considered as we try to understand the prodromal and active stages of Alzheimer's disease. So to give you a little bit of background, intra-individual cognitive variability, or IICV, is not new. It goes by many names, but we're going to call it this for the purposes of this study. It refers to within-person across-test variability. This can be difference in test performance across different cognitive domains at one time point, or this can be referring to variance in performance on a cognitive test across multiple time points. For the purposes of this study, we looked at participant performance on cognitive tests across multiple domains at one time point. We know that greater variability on cognitive tests has long been viewed as an indicator of brain dysfunction. We also know that everyone has some degree of naturally occurring variability, but larger degrees of variability are more clinically concerning. So how many people are familiar with the R bands, repeatable battery for the assessment of neuropsychological status? Okay, so some people. So I'm going to show you some R bands overview sheets because I think it provides a nice illustration of what I'm talking about here. So you see here we have all the different cognitive domains, and then we can plot the test scores here. So these are index scores. The dark gray shaded area here is one standard deviation above and below the mean. So in this first profile, this is somebody whose ability level is generally in the average range. They demonstrate some variability across domains. That's someone who's probably cognitively healthy. This second profile here is somebody who is still exhibiting a normal amount of variability. They just might have a lower baseline ability level. But this third profile here, you can see there's a greater degree of variability here. Can't see if this is pointing. This is an example of a profile we often see in memory clinic in someone who has cognitive impairments that are likely due to Alzheimer's disease. I want to also kind of show this hypothetical model of IICV over the disease state. So we have on the x-axis here the progression of Alzheimer's disease, and then on the y-axis we have IICV increasing. So as you can see, people will start here at cognitively healthy. So that's kind of that first R-bands profile I showed you. Then as they progress through the disease state, they have an increase in their degree of variability. And so that's kind of when we're seeing them in clinic. And then as they progress and meet criteria for dementia, they become more globally impaired, and so they demonstrate less variability, but it's due to the level of impairment. So some work done here at the University of Wisconsin in the Gleason lab found that IICD predicted incident dementia. So IICV was found to have similar predictive power to cerebrospinal fluid biomarkers and hippocampal volume loss. And then we also found that some group differences exist. For instance, African Americans demonstrate a greater amount of IICV at baseline than Caucasians. So our objectives were to determine if baseline IICV could predict hippocampal volume relative to intracranial volume in a younger preclinical cohort, and to analyze subject characteristics that might influence IICV. So we included 368 participants from the ADRC clinical core. We wanted to have a wide range of different levels of functioning, but we did not include people who met criteria for dementia at baseline because we were more interested in the prodromal phase. We chose tests that are expected to show dispersion across the Alzheimer's disease process. So we had Boston naming test or multilingual naming test. Participants would complete those depending on when they entered the study, but we converted MINT scores to BNT scores using NAC crosswalk study data. We also included the sum of learning trials and the delayed free recall trial from the Ray auditory verbal learning test. This is a test of learning and memory of unstructured verbal information, so a list learning task. And then the trail making test forms A and B. An example of why we chose these tests with trails, form A is something that is simple visual scanning and processing speed. Form B has that same component, but with an added mental flexibility and set shifting component that we would expect to see change earlier on in the disease process. So we included those because they would, persons progressing through the disease process would demonstrate variability on those measures. To calculate IICV, we used a dispersion rather than a pattern-informed IICV calculation. Individual z-scores were calculated for all 5 test scores based on mean group performance, and the standard deviation between the z-scores was calculated to determine variability across tests. We performed a regression analysis to determine if IICV could predict hippocampal volume in relation to intracranial volume. We included age, sex, ApoE, epsilon 4, carrier status, years of education, and family history of dementia due to Alzheimer's disease in the model. Long story short, we didn't have any significant findings there. However, we did notice some differences, some sex differences within the cohort. So this is a data table that kind of provides an overview. So in terms of the distribution of diagnoses between males and females, it was rather similar. They were of similar age at baseline. We didn't do a statistical analysis to look at race, but it seems to be pretty evenly distributed. We did see a difference in years of education. So female participants had an average of 16 years of education, whereas males had an average of 17 years of education. Overall, this was a very well-educated sample, kind of ranges, you could say, from an associate's degree to a master's degree. Parental history of dementia due to Alzheimer's disease, about 70% of all participants had a parent with a family history of dementia. And then we saw a difference in hippocampal volume relative to intracranial volume. So in females, we actually saw that it was larger than in males. And then dispersion IICV in females was also larger than it was in males. So it's kind of an interesting finding when you see a larger hippocampal volume and also a greater degree of cognitive variability. We then analyzed the relationship between relative hippocampal volume and baseline dispersion IICV. We saw a very weak positive correlation in females, but we did not see a significant correlation in males. This other figure here is just a box plot of the difference that I described earlier. So why are we seeing these results? Well, several studies have actually revealed that sex differences exist in brain aging. So we see less memory impairment in females, less hippocampal atrophy in females, and if we consider metabolic brain age as opposed to chronological brain age, the female brain appears to be about 4 years younger than the male brain. And this is an interesting finding by Goyle and colleagues, is that this was not affected by amyloid deposition. There are several hypotheses as to why this might be occurring. One is that it might be due to heightened glycolysis in female brains. However, they suggest that it's likely a multifaceted biopsychosocial process. Another reason we might be seeing this, I want to bring back this hypothetical model of IICV. I added this line that's supposed to kind of represent hippocampal volume decrease over time. Depending on which part of the disease process a participant is in, if they are having a decrease in hippocampal volume and their IICV is on the downward trend because they're becoming more impaired, that might be another reason why we see this weak positive correlation. So some discussion points in future directions. Again, I want to reiterate, this is a rather homogeneous sample that's about 90% Caucasian, and most people were pretty well educated. We use a dispersion model of IICV, which is a limitation because while it gave us the magnitude of IICV, you could have the same amount of IICV if you were someone who has really well-developed memory skills and kind of executive functioning skills that are in the average range. That's a very different clinical picture from somebody who has preserved, trails A and naming ability that then has learning memory and then trails B kind of at a little bit of a lower level. I also want to mention that participant sex was limited to binary assumptions, so there was no demographic questions that were used to capture gender identity in the sample. Some future directions are to determine if the test results determine if these results might vary in different racial groups, and then we also want to see if there might be a correlation between IICV and age. So again, the take-home message is that differences based on subject characteristics need to be considered as we try to understand the prodromal and active stages of Alzheimer's disease. All right, so these are my acknowledgments. Thank you so much to the participants and their families. Thank you so much to my mentors and supervisors at the VA where I'm completing my internship. Thanks to Dr. Gleason. She is one of my amazing supervisors at the VA. And thanks to all of our collaborators, especially Derek Norton, because he put up with all of my stats questions the entire time. So, thank you very much.